This morning when I was talking to Ken, I said, Ken, you just better not say anything profound, before I get up and talk. And, thanks a lot. In any case, I'm going to try to address 4 questions. First of all, what do the studies by Tyler contribute? Second, should clinicians encourage attendance among the religious, as Ken was talking about? Next, what takes place during a religious service that affects health? And then important areas for future research. Okay, so, well, one of the things that's done, Tyler's work, is it's confirmed a lot of research that's been going on for the last 50 to 60 years. It's also addressed some of the criticisms that Richard Sloan and others have made concerning this field, including inadequate control for confounders, investigator bias, file drawer phenomena, claiming more than the data actually shows in terms of causality. It also, as Ken said, it raises the level of the methodological rigor. Large samples, in these data sets, longitudinal data, multiple assessments of exposure and outcome over time, sophisticated methods of analyzing this data that have not been used before. And in particular, it's this research has been published in mainstream journals. JAMA, American Journal of Epidemiology. The one on suicide was published in JAMA Psychiatry, which used to be the Archives of General Psychiatry. To my knowledge, there has never been a study on religion and health published in the Archives of General Psychiatry before, in, I think, almost 100 years. So these studies with this kind of rigor are so significant in terms of mainstreaming this research into real, medical research, medical science. And so that's why I think it's made a huge contribution. And also coming from here. I mean, there's no question about it. Coming from here, from the School of Public Health at Harvard, just immediately gives it credibility, particularly in a field that has been kind of on the margin. Now, what should clinicians encourage attendance among the religious? And I really, Ken did a beautiful job in doing, saying just about everything I had to say, but in any case. You got a socially isolated patient. I see patients, in my practice, geriatric, they got multiple medical problems, the caregivers are stressed out. They can't go out and participate a lot of times. They've stopped attending church because they can't get there. And it's they become socially isolated. And, it's a big issue. So if you've got a patient like that, and they're religious, and they've previously been an attender, what I'd like to know, and you have to do this sensitively, you can't go in there like, bull in a china cabinet. You've got to do it very sensitively. I want to know, okay, what's prevented you from attending? Like, you used to go, was that helpful? Did you enjoy that? What stopped all that? And then they'll say, well, such and such, I can't get there. So I say, well, would you like to brainstorm with me on ways that maybe you and your family could make that happen, or maybe the church even could make that happen? So to me, it would just seem to be natural to try to explore something that might help that person become less socially active and more socially engaged. And there's very few things, particularly for older adults, that you can really specifically say get socially engaged in. If you want to make a recommendation, and what other group is so readily available just about everywhere, on just about every corner, there's some kind of a religious, a church or institution. So, let's look at, would it hurt the patient? Let's look at the risk-benefit ratio. It could induce guilt. People could, you know, if you say, okay, well, you try increasing your attendance, they go to church, they get kind of guilty. It could cause unrealistic expectations. You know, you might say, okay, well, you know, there's been some work at Harvard by this amazing statistician that's shown that if you go to church, you're going to live longer. You know, your blood pressure is going to drop. So, you know, an atheist, you know, wanders in and says, well, gosh, I think I'll go. So he goes into church, he sits there, he listens to the message, then he starts feeling a little guilty. And then his blood pressure goes up and he has a stroke. And then he, you know, that wouldn't be good. And so, but that could happen. Now, on the other hand, it could provide that social support, you know, from others with similar beliefs and values. It could produce a social environment that generally fosters a healthy lifestyle. You know, one of the big issues in getting people, you know, people with addictions to stop alcohol or drugs is to get them in a different social atmosphere as opposed to all their friends being other drug users or alcoholics. And so here's a group that generally is very, advocates a healthy lifestyle and you know, it just would, you know, would seem good for the patient. With the possible exception of calorie intake. Now, there is research showing that religious people, you know, are bigger than the non-religious. So now, it might also provide all the benefits of regular involvement in any social group. You know, we kind of talked about that, including information flow. You know, in religious organizations, you know, you talk to each other and they say, hey, you know, have you had your breast mammogram? You know, or have you had your prostate exam, like that, well, whatever. And you just talk and information gets passed, health-related information, or there might be a health program in the church. And all of that would help to educate, et cetera, in terms of their own health. Very practical issues related to health. Okay. So the next question is, what takes place at a religious service that affects health? Okay. Well, physical activity. You know, to get to church. You know, in the morning, on Sunday, I've got other things I'd like to do besides go to church. I'd like to sleep in, and I'd like to watch, you know, a football game or whatever, or I like to go fishing or hunting. But now I have to get up, I have to take a shower, I have to put on my clothes, I have to get in the car, I have to drive there, I have to park, I have to walk into the church building, and then, you know, depending on if you're Protestant or Catholic, you know, if you're Catholic, you're kneeling, standing, sitting, you know, and there's a lot of activity there. And then you have to walk back out to the parking lot, find your car, you know, and then a lot of times people go out to eat, and so there involves driving somewhere. Again, a lot of physical activity. And that's true also not just in Christianity, but in Islam as well. I mean, you know that in the four or five daily prayers, there is a bowing. I actually, in Saudi Arabia, I've gone to the mosque, and I've participated in some of that. There is a bowing, and there's a lot of activity that goes on during that. I mean, there's the bowing down with the head on the ground, touching the floor. In fact, there's actually many people, it's considered actually a sign of being very spiritual, have actually a scab here where the head has touched so frequently the ground that there's actually a callus has developed there in the forehead. So in any case, physical activity, it is, you know, might increase it. And of course, meeting people, positive social interactions, making contacts for activities after the service, during the week. I mean, many women in particular, since, you know, the suicide surveys in women, they get together, they have child care activities together, they socialize. There's all sorts of things that go on during the week. It's not just that service attendance for that 30 minutes or hour on Sunday. It's a lot more. Then there's singing and praying and worshiping together with others who have similar beliefs, reinforcing those beliefs, reinforcing the worldview. and serving as a stress reliever in the African American community. The shouting, the amens, it's a stress reliever after a hard week. The religious service was a way to get it all out, to sing and praise God. And so it was a way to get it out, all that stress. For at least an hour it would go. And, throughout history, many of the major religions, sacrifice, rituals that go on during a service. We don't, have sacrifice now, but early Hindus in the Vedas and the Upanishads, it talks about the sacrifice being of crucial importance. Of course, in Judaism, exactly the same thing. The sacrifice, and then in Christianity, it was Jesus, the sacrifice, God being the sacrifice. So all of these things probably have effects on people, unconscious effects through the rituals and the various things that go on in a beautiful, awe-inspiring place. Listening to the sermon, usually about things related to human or divine relationships, that helps to strengthen them. Information flow, as I said earlier. Okay, so what are some important areas for future research in religion and health? Cross-sectional studies. Not all are worthless, and Tyler said that. He did say that not all. Most of them are, but not all. So there are some, particularly, as he said, where there hasn't been anything looked at yet. You got to establish an association. That would help. And so that's what cross-sectional studies do. And in this field, there's almost an unending number of research questions that have not yet been answered, that need to have at least some kind of association. Also with biological outcomes. In particular, we don't have many associations, studies cross-sectional, even with biological, endocrine, immune, genetic, various kinds of markers, telomere lengths, whatever. And also looking at these cross-sectional associations in non-Western settings. For example, in the Middle East or in China or in Europe, doing these kinds of large cross-sectional studies. Prospective studies, of course, and now, of course, the cross-sectional studies cost the least, which is a factor. Prospective studies, naturally, more large random samples, long-term follow-up, and, of course, the work here by Alexandra Shields will be inserting religious variables in some of the incredible data sets that here at Harvard you have, that you've started, you're monitoring or you're leading, just including a few religious variables in those data sets so that there is a long-term study, and these kinds of analyses can be done. Of course, the outcome and the exposure being assessed at multiple time points so that these analyses can be done. And then, in particular, really looking at religious history. It's not, we measure religious attendance on how often do you attend now, but what about how long they've been attending for their whole life? Has that not resulted in an accumulation of benefit over time? Are we not going to even consider that benefit that's accumulated over 60, 70 years? If you ask somebody about cigarette smoking, what do you ask them about? Pack year history of smoking, right? That's the exposure. So we're not really doing that, but we need to do that. Okay, and then randomized clinical trials, naturally, those are issues. Let's see here, what am I doing? Yeah, we did that. So randomized clinical trials. Very expensive, hard to do, but of course, if you look up at Tyler's slide again, it's actually, he should have put those at the top, but they are the sine qua non of evidence base. Randomized clinical trials. That's what medicine, that's what all of healthcare sees as evidence-based practice, based on randomized clinical trials. In cognitive behavioral therapy, there are hundreds of meta-analyses of randomized clinical trials justifying the use in clinical practice of cognitive behavioral therapy. But these are, and this comment, often not possible with religion, Tyler, it is possible. We do horrible things to people, believe me, in randomized clinical trials. We give them poison, basically, in drug studies. It just depends on whether, informed consent and there's a potential benefit. So you could potentially you could take atheists and randomize them to attend religious services. You probably have to pay them to do that, but that'd be okay. You know, you pay people to do things. You could do that, but more likely what you would do is you would get people who are already a little bit religious, and you would simply, and it would be open to being, you know, a religious intervention, and you would do that intervention with those who are randomized to that group, explaining, you know, the chances that they might get this, and this is what they would have to do. So it could be done. It could very well be done, and so I wouldn't rule that out. They are expensive, and you know, sometimes you can find things you didn't want to find, particularly if it's not done well. In other words, an effective intervention shown to not have any effect simply because it was managed not well. The randomized clinical trial was not managed well, which is a huge, huge task to do well. Now, what about applications? You know, we don't know, Ken brought up many important things. We don't know what happens if somebody gets a spiritual history, or if somebody is suggested, well, go to church, or if somebody decides they're going to pray with the patient. What are the effects of that? So the clinical trials, you could design clinical trials where you could look at that and actually see whether or not that causes harm or might have benefit. Now, one example is chaplain intervention studies. I'm going to close on this one. You know, tremendous lack of an evidence base for chaplains. Chaplains are clinicians. They're not trained to do research. They don't really, you know, they don't grasp research easily because they care about people. They love people. They want to help people. And research is so different than that. You know, it's so rigorous. You know, you have to be a little introverted to do it. You can't be very extroverted. So, you know, chaplains are not like that. They need to partner with researchers and learn to design and manage these trials themselves. And I know the Templeton Foundation has contributed to, you know, a large initiative where chaplains are learning some literacy in the research. But they need to learn to do the research themselves or work with those who do it. Okay. Now, one little thing at the end here is, you know, what you could do is you could design a clinical trial looking at something else and use the chaplain as the control group. And then you'd have data then on chaplain interventions. Now, believe it or not, that was done in one study in 1992 looking at cognitive behavioral therapy, compared religious cognitive behavioral therapy with conventional therapy, with pastoral care. It was a control group, or like no treatment. And so after 2 years, the finding was that, guess which group did the best? It wasn't the conventional CBT, it wasn't the religious CBT, it was this pastoral care group that had the best results over time, over a 2-year follow-up. So, in any case,